Hello, awesome staff of the Northwest Kidney Center. Welcome to the Thanksgiving edition of our monthly in-service. Shout out to the amazing staff at the Kent Northwest Kidney Center unit and our little sister unit, Panther Lake. Today we're going to talk about bloodstream infections in dialysis patients. I know what you're thinking. What does this topic have to do with Thanksgiving? Well, nothing, except for the fact that I'm very thankful that I don't have an infection at this time. The reason for the topic is independent of the holiday. In the last month in Kent, we have had 2 bloodstream infections and 6 cases of sepsis. So the purpose of today's in-service is to bring awareness to these important dialysis complications and to help you understand their clinical significance. Infection is the second most common cause of death among dialysis patients, and bloodstream infections are the most common cause of infection among maintenance dialysis patients. So it's really important that we recognize when they occur and know how to both treat and prevent them. There are 3 objectives to today's talk. I want you all to understand the significance of bloodstream infections in dialysis patients, recognize their clinical presentation, and review treatment and prevention options. I want to begin with some basic definitions of terms that I will use during this talk. First, what is a bloodstream infection? So, as the name implies, it is an infection of the blood caused by a blood-borne pathogen, which can be a bacteria, a fungus, or a virus. You should not have any of these within the bloodstream. So if you detect their presence, it is always abnormal. And sometimes it can precipitate an extreme reaction on the part of the immune system and lead to something called sepsis. So what is sepsis? Sepsis is a life-threatening condition caused by the body's immune response to an infection, and often it can lead to organ dysfunction and sometimes even death. Common signs of infection include a low blood pressure or hypotension, a fast heart rate, a fast respiratory rate, and confusion. And sepsis is a really big deal for everyone, but in particular for dialysis patients. The annual mortality due to sepsis, if you're a dialysis patient, is 50 to 100 times higher than that of the general population. And as I mentioned earlier, we've had 6 patients with sepsis at our unit within the past month. So it's definitely an issue with which we need to be familiar. Let's begin by discussing the epidemiology of bloodstream infections in dialysis units. So bloodstream infections are very common infections among maintenance hemodialysis patients, and they're associated with high morbidity and mortality, much worse than the general population. And the problem appears to be getting worse. From 2003 to 2012, the rates of bloodstream infections and sepsis and hospitalization for sepsis in the dialysis population increased by 40%. So why are dialysis patients at increased risk for bloodstream infections? The main reason is because dialysis catheter use is so prevalent. Catheters are the #1 cause of bloodstream infection in dialysis patients. Now, you've heard us mention that there's so many reasons why we strongly prefer patients have a dialysis fistula or a graft, and a high risk of infection associated with dialysis catheter is #1. In the United States, approximately 80% of incident dialysis patients initiate dialysis with a tunneled catheter, and approximately 20% of all prevalent dialysis patients use catheters on a long-term basis. Catheter-related bloodstream infections typically occur with a frequency of 1 to 2 episodes per catheter year. In one study of 472 dialysis patients with newly placed tunneled hemodialysis catheters, 35% developed a bloodstream infection within 3 months, and 54% had developed one by 6 months. The incidence of bacteria in the blood, or bacteremia, it's about 10-fold higher in patients with tunneled catheters compared with patients who have fistulas or grafts. Additionally, 2 to 3-fold higher risk of infection-related hospitalizations and infection-related death compared to patients who use fistula or grafts. And all of this, translates into bad clinical outcomes. In the hemo study, for example, 7.6% of all dialysis patients had catheters, and yet this small group comprised about a third of all of the hospitalizations for access-related infection. There's also a large prospective study done of Scottish dialysis patients on hemodialysis, and they found that the use of a tunneled catheter was associated with a 7-fold higher risk of death compared to patients who used an AV fistula or a graft. So all of this is just a reminder that we need to get catheters out of our patients and fistulas and grafts placed in their arms. Other risk factors for bloodstream infections in dialysis patients include recent surgery. Say you operate on the arm and they could potentially get a wound infection that can lead to bacteria in the blood. Diabetics are relatively immunocompromised and are in greater risk for infection. Iron overload, so that's a complication that we cause by giving them too much intravenous iron. There is some thought that iron may be trophic or stimulate the growth of bacteria. Immunosuppression, lots of our dialysis patients have had failed kidney transplants and yet are maintained on immunosuppressive therapy. And finally, low albumin, which is not a perfect, but nevertheless used as a marker for poor nutritional status. Okay, let's now discuss the microbiology of bloodstream infections in dialysis patients. Some bacteria have a thick cell wall that, when stained with a dye called crystal violet, turn a purple or a blue color, and we call these gram-positive bacteria. For example, Staphylococcus or Streptococcus are gram-positive bacteria. Gram-positive organisms are responsible for most of the hemodialysis catheter-related bloodstream infections. The number one cause is Staphylococcus, which in some studies accounts for upwards of 60 to 80% of cases. Some cases of staph are coag negative and others are coag positive, such as Staph aureus. Now, gram-negative organisms, which you can see over here on the right, lack the thick cell wall that would turn or stain blue on the gram stain, and these account for about 20% of the infections. Then finally, we have polymicrobial infections or multiple bacteria, which account for maybe about 10% of all episodes of catheter-related bloodstream infections. I want to spend a moment talking about Staph aureus, which causes most catheter-related bloodstream infections in dialysis patients and also causes the greatest morbidity and mortality. The word staphyle means cluster, as in a cluster of grapes. Coccus means berry or seed, and aureus is a Latin term for gold coin from ancient Rome. So basically, it's a cluster of golden berries, is what you see on the photomicrograph. Staph aureus is commonly associated with significant morbidity and mortality, particularly in the dialysis population. There was a study published by Denis in 2006. It was a retrospective cohort study of 22,000 hospitalization hemodialysis patients with septicemia, and the death rate of patients with Staph aureus after 12 weeks of follow-up was 34%. So a third of patients died when they had Staph aureus bacteremia. It's 20% higher than the death rate of infections from bacteremia due to all other organisms. So Staph aureus is the number one pathogen that kills dialysis patients. A study by Nissensen in 2005 looked at 11,500 admissions of hemodialysis patients for Staph aureus bacteremia and had one or more complications. Most people were in the hospital for 2 weeks, and 12% of those patients needed readmission for the hospital within 12 weeks for treatment of a relapsed infection. So relapsed infections are relatively common. A subtype of Staph aureus infection is MRSA or MRSA, methicillin-resistant Staph aureus. This is another really important pathogen in the population. It's a type of bacteria that is resistant to an antibiotic called methicillin. So it can't be treated with methicillin and sometimes other antibiotics as well. And because of its antibiotic resistance pattern, MRSA infections are often a little bit more complicated to treat than infections caused by other bacteria that are not antibiotic resistant. In this case, we treat it with vancomycin, which we commonly use in dialysis units, at least until we know what the bacteria is. We tend to give people vancomycin while waiting for the culture report to let us know what antibiotic is best suited for that particular infection. Non-staph infections are most commonly enterococcus and gram-negative rods. Again, these account for maybe 20% of all the catheter-related infections that we see. And then a small percentage are due to either polymicrobial infections or uncommon pathogens such as yeast and fungi. So how do dialysis catheters get infected in the first place? Well, there are two potential mechanisms. First, bacteria can migrate from the skin along the outside of the catheter into the bloodstream. One of the features of a tunneled dialysis catheter that makes this less likely is something called the cuff, and I've circled it over here, and the cuff is shown in yellow. Basically, it's a Dacron cuff, and it incites a fibrous response so that scar tissue forms around, and that serves two purposes. One, to anchor the catheter in place so that it's not movable. And the second thing is it prevents, the scar tissue serves as a barrier to prevent bacteria from migrating past the cuff along the catheter into the bloodstream. So it's a mechanical barrier against skin flora. Second way that catheters can be infected is by direct inoculation. So catheters oftentimes get coated with something called a biofilm when they're in place for a long time, and microorganisms can basically adhere to the biofilm. And we get bacteria in our blood all the time, say when we brush our teeth or have a bowel movement, or if your gums bleed or whatever. It's very common to get a little bit of bacteria that our immune system really fights off, but again, if you have bacteria in your blood for 5 minutes, it can stick to the biofilm on the catheter. Let's now discuss the clinical presentation of bloodstream infections in dialysis patients. The most common presentation of a bloodstream infection is fever and chills. This is why we take it very seriously if a patient has even chills during the dialysis procedure. So the presence of fever or chills in a catheter-dependent hemodialysis patient in one study was associated with positive blood cultures in about half of the patients. So it's a pretty good marker for bacteria in the blood. If any dialysis patient has a fever, certainly a fever or shaking chills on dialysis, very important to draw blood cultures, particularly if they have a catheter. Some dialysis patients with a bloodstream infection will also demonstrate evidence of an exit site infection. So basically, an exit site is the site where the catheter exits the skin and the chest wall. And the presence of an exit site infection does increase the likelihood of having bacteria in the blood. Although, it turns out that most dialysis patients who do have a catheter-related bloodstream infection don't actually have evidence of an exit site infection. This was shown in one study by Sitchev, published in 2011, looked at 1,436 episodes of catheter-related bloodstream infection and found that only about 5 to 10% of those had evidence of an exit site infection. So, the presence of an exit site infection strongly predicts the concurrent presence of a bloodstream infection, but the absence of erythema or drainage from a catheter exit site definitely does not exclude the possibility of a catheter infection. So it doesn't provide us a lot of insurance in a febrile patient or a dialysis patient who has chills if the exit site looks good. Other clinical manifestations of a bloodstream infection may include what we call hemodynamic instability, so low blood pressure. Patients are often confused. Sometimes the catheter doesn't work well. And we are always concerned about the possibility of developing sepsis, which we talked about earlier as a syndrome featuring fever, fast heart rate, low blood pressure, confusion that is triggered by our body's immune response to an infection. Bloodstream infections can cause a lot of complications. So once bacteria in the blood, they can travel to other parts of the body and cause what we call a metastatic infection about 5 to 10% of the time, from the Greek word metastasis, or migration or change. And you've heard that term used for cancer, but we use it to describe infections as well. So when an infection starts in one place and goes to another, we call that a septic or a metastatic infection. It's important to note that metastatic infections may not be immediately apparent. Sometimes, a patient will have a fever, we give them some antibiotics, but we don't realize that they have, infection in their lungs or infection in their brain or infection on their heart valves until long after the initial bacteremic event. Some septic and complications may include osteomyelitis. Osteo is the Greek word for bone. Myelos means marrow, and itis is inflammation, so an infection of the bone, osteomyelitis. Endocarditis, endo means within, cardia, heart, itis, inflammation, so infection within the heart, specifically of the heart valves. Septic arthritis, infection of a joint space. Epidural abscess means infection within the epidural space, anywhere within the brain or the spinal cord. And meningitis, or infection of the fluid and membranes, which are also called meninges, around the brain and spinal cord. Okay, let's discuss the diagnosis and prevention of bloodstream infections in dialysis patients. When should you suspect a catheter-related bloodstream infection? Basically, in any dialysis patient who happens to have a catheter plus signs or symptoms of systemic infection, so fever, chills, etc., particularly when there's no obvious alternative source like, everyone in the family has COVID or something like that. The diagnostic approach always begins with a basic history and physical examination. Depending on what you find, then we consider other radiology or laboratory tests, such as, a chest x-ray or blood cultures or a viral screen. Just remember that a dialysis patient with a catheter who has a fever has a catheter-related bloodstream infection about 85% of the time. So essentially, fever in a dialysis patient with a catheter is a catheter infection with bloodstream infection until proven otherwise. You establish the diagnosis by obtaining 2 sets of blood cultures prior to administration of antibiotics. Blood cultures can be obtained, from the hemodialysis catheter, from the hemodialysis circuit. In theory, you can obtain it from peripheral veins, but we don't typically do that in a dialysis unit. You want to get a minimum of 10 milliliters of blood from each site. Say you get it from each, catheter port. And of course, if they have any evidence of an exit site infection, you want to culture any visible drainage as well. For patients who get sent to the hospital, we will do additional testing. If there's a high index of suspicion for catheter infection, the catheter will be removed and the tip sent for culture. Typically, we'll get a chest x-ray to look for pneumonia, which can occur secondary to the bacteria in the blood. If they still make urine, we'll get a urine culture. If they have persistent bacteria in the blood, we will order an echocardiogram or an ultrasound of the heart, specifically to look for any sort of growth on the heart valves. We call that a valvular vegetation or endocarditis. And if someone complains of joint pain, say in the knee or the ankle or the shoulder, we will insert a needle into that joint space to look for infection. We call that septic arthritis. So how do we prevent catheter-related bloodstream infections? The most important thing, of course, is not using catheters in dialysis patients and encouraging them to go to their vascular surgeon to get the catheter removed if their fistula is working well. And of course, when we work with the catheter, we have to demonstrate excellent sterile techniques. So, of course, you start use hand hygiene before putting on the gloves. You follow the Northwest Kidney Center protocol carefully when accessing the catheter and cleaning the catheter ports and the hubs. Don't let the hubs touch non-sterile surfaces like the chest wall. Hold the hubs up until the antiseptic is dried, and then you put on the disinfecting caps. All right, what have we learned today? Today we discussed that the majority of bloodstream infections in dialysis patients are caused by infection of the dialysis catheters. Potential complications, aside from hospitalization and mortality, include sepsis and what we call metastatic infections, so infections of the heart valve or endocarditis of the bone or osteomyelitis of the joint space or septic arthritis and epidural abscess. The most common cause of infection is a gram-positive organism known as Staphylococcus. Most common presentation is just fever and chills. Exit site infections are a good thing to look for, but they are uncommon. The most serious presentation can include sepsis syndrome. Again, typically presenting with fever, a fast heart rate, a low blood pressure. The diagnosis of a bloodstream infection is made with blood cultures, and the treatment, of course, includes antibiotics and catheter removal. And now, time for the monthly quiz to assess your comprehension. Question number 1, this organism is the #1 cause of bloodstream infections in dialysis patients. That's right, Staphylococcus. Most often we see Staphylococcus aureus. Question number 2. Do most dialysis patients with dialysis catheter bloodstream infections have evidence of an exit site infection? The answer is a hard no. So again, exit site infections are only present in about 5 to 10% of catheter-related bloodstream infections. Again, it's a good thing to look for, and if they have purulence or erythema, you want to culture it, but otherwise they are uncommon. Question number 3, name 3 complications of a bloodstream infection in dialysis patients. That's correct. So sepsis, again, we had 6 patients this past month at our unit who have had sepsis, osteomyelitis, infection of the bone, endocarditis, infection of the heart valves, septic arthritis, infection of a joint, and epidural abscess. Question number 4, what is sepsis? So as we discussed earlier, sepsis is a complication of infection caused by the body's immune response and often leads to organ dysfunction and sometimes even death. So it's a very bad manifestation of infection. Final question, what percentage of dialysis patients in the United States start dialysis using a catheter? That's right, it's a whopping 80%. Now that's actually not what we see at the Kent dialysis unit, where about 70% start with a dialysis fistula in place, which is quite remarkable. This includes the Thanksgiving edition for the Northwest Kidney Center, November 2024. I want to just add how grateful I am and thankful that I work with such awesome people at the Kidney Center. You guys are amazing. My patients are so grateful and give me feedback all the time on how much they appreciate everything you do. So know that you are appreciated and loved. Happy Thanksgiving to all of you. Bye-bye.